Every day we are exposed to hundreds of chemicals. Some we've known about for many years, while others have been recently created or discovered, or we've developed ways to measure their presence for the first time. For some of these chemicals, we know their effect on people, and some we don't. In 2007, the Minnesota legislature established the Environmental Public Health Tracking and Biomonitoring Program for the purpose of tracking people's exposures to a variety of chemicals and monitoring the health effects of these chemicals. This program provides information for programs and policies that might reduce any potential health impact of these chemicals and helps us evaluate their effectiveness. We're going to talk about the Environmental Public Health Tracking and Biomonitoring Program on today's episode of A Public Health Journal. Please stay tuned.
Welcome to A Public Health Journal, a program that explores the public health issues facing our society today and tomorrow. The host of our show is Dr. Ed Ellinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health, the Hennepin County Human Services and Public Health Department, and the Minnesota Public Health Association, all working together towards the goal of healthy people living and thriving in healthy communities.
Welcome to A Public Health Journal. Today we're going to talk about the Environmental Public Health Tracking and Biomonitoring Program within the Minnesota Department of Health. It's a program that tracks exposures to chemicals in vulnerable Minnesota populations with a particular focus on pregnant women and children and communities disproportionately exposed to environmental threats. The goal of this program is to provide data to inform decisions and evaluate actions for protecting future generations from the chemicals within our environment. Joining us in this discussion is Dr. Jean Johnson, an environmental epidemiologist and the director for Minnesota's Environmental Public Health Tracking and Biomonitoring Program at the Minnesota Department of Health. Jean, welcome to our program.
Thank you. Glad to be here.
You have a long title in this public health, biomonitoring and tracking, environmental health. So let's try to talk about tracking and biomonitoring as the sort of the shorthand of what we're talking about. So tell us a little bit about what is this program all about?
Sure. Well, environmental public health tracking and biomonitoring in our state, that work actually started 10 years ago. We're celebrating the 10th anniversary of state legislation. It's passed in 2007. What the legislation did was to create a program to bring together data about environmental hazards, chemical exposures, and people's health so that we can better understand what those relationships are and get a better picture of what the issues, problems, actions that are needed in our state.
Now we've had concerns about chemicals in the environment for decades. I've grown up with the idea of DDT in the environment and all of those kinds of things. Right. Why in 2007 did this program get created?
Well, I think 2007, a couple of things were going on at that time. For one thing, the CDC had created a national environmental public health tracking program, and at that time, the funding for that started in 2003, but they were only funding 16 states in the network at that time. And so there were folks in our state who were very interested in seeing Minnesota be part of that network and do some of that same work. So the legislation they wrote very much took from what was going on nationally and the work that other states were doing to develop these tracking programs. At the same time, what was also happening in Minnesota was the discovery of the perfluorochemical contamination of drinking water in the East Metro.
PFCs, right?
PFCs, yes, although now we refer to them as PFAS, PFAS. Which actually for those communities, they were very interested in the state having the capability to go into communities and measure chemicals in people's bodies, so in blood and urine samples, which at that time we did not have the capacity to do, so we could not respond in that way. So this legislation kind of brought those two interests together. The folks who were very interested in we would have a tracking program looking at data, and the folks who were also very interested that we would have this capacity to measure chemicals in people.
Yeah. So tell us the difference, the tracking and the biomonitoring. What's the difference in that?
Well, one difference is, as I mentioned, tracking, it is connected to a much larger federal program network of states that we collaborate with under a cooperative agreement. And it uses what we call secondary data, or data that already exists out there. We're not going out and collecting new data. We're going to various programs and partners and pulling in data. Whereas the biomonitoring program is very community-based. It is just focused on communities in Minnesota, and we are going out and collecting new data, collecting blood and urine specimens from people. Our laboratory does that analysis work, and then we report that data back to the community.
Yeah. So in the case of the perfluorochemicals in the East Metro, you monitor blood levels in folks over the years to see if it's going up or down or staying the same. That's the biomonitoring piece.
Yes.
All right. Now I've got a slide here that shows some of the tracking data and measures. I'm going to put that on the screen, and maybe you can talk through what are we looking at, what are we monitoring, and what are we evaluating?
Sure. So this slide does show kind of nicely the sort of the breadth of all the data that we are collecting in the tracking program. And as I mentioned, we're doing this in collaboration with other states as well. So we collect information on environmental hazards, and in addition to chemicals, this also does include physical hazards and some infectious hazards as well. So we collect information on air pollution that we get from our Minnesota Pollution Control Agency. We collect drinking water data from our own agency's drinking water programs, radon data, which comes through our indoor air quality programs, and traffic. So those are some of the hazards that we look at. On the health outcomes side, we look to a lot of our disease surveillance programs for this data. So we collect cancer data from our cancer registry, asthma, COPD, heart disease. These are all health outcomes that we know associate with environmental hazards. On the exposure side, that is our biomonitoring data. So it includes the things that we are measuring in human samples: lead, mercury, cotinine, which is a marker of tobacco exposure, arsenic, and the perfluorochemicals. And then we also do have some information on other risk factors that we know are important to health, and that's those social factors, so those social determinants of health. We include things like obesity, poverty, health insurance, and that's just because that's such important context to understanding people's environments and how that affects health.
So how do things get on this list? As I mentioned in my introduction, we have thousands of chemicals, and new chemicals are coming on all the time. How do they get added or taken off on this list?
So some of the topics are determined by our federal grant with the CDC. The CDC does want national consistency. So all the states work together to collect in the same way nationally consistent data and measures. So some of the topics are determined by that. But states also have flexibility. We can also choose topics that are important in our state that maybe other states aren't looking at. Or maybe we have data sets that other states don't have. One of the ways that we do that is we have an advisory panel that was established through our legislation. They have a role in helping us sort of look at what are the priority hazards, what are the priority health conditions for us to look at, and they help us make those decisions as well. Good.
Well, we're going to take a little break, and we've got a little video that goes through some of what the Centers for Disease Control and Prevention talks about in this. So we're going to take a little break, and then we'll come back.
Great.
So we'll be back right after this message and this videotape.
Our personal health is affected by the health of our environment. We must care for both to stay healthy. Understanding our connections to the world we live in is important. The Centers for Disease Control and Prevention is working to improve our understanding of those connections. CDC's Environmental Public Health Tracking Program uses a broad network of experts, data, and tools to connect environmental and public health information. This allows us to drive innovative programs and solutions that protect and improve the health of communities across the country. One way CDC's tracking program does this is through the Tracking Network, a dynamic system that provides researchers, public health professionals, and the public with information and data about environmental hazards and the health problems that may be related to them. However, the tracking program is more than just data. Its resources and expertise help community leaders make informed decisions about allocating resources, planning interventions, and evaluating efforts to improve public health and potentially save lives.
Environmental public health tracking data are tremendously useful in planning purposes. They're tremendously useful in environmental regulatory decision-making purposes, and they're useful in prevention activities.
So much of what we do in public health relies on good, sound data. The thing that we're excited about with this dashboard is that it begins to allow us to have a more efficient use of that data, a more efficient use of staff time, and we can begin to pull data sets together to establish some of those understandings about what may be going on here between the environmental exposures that are out there and the health outcomes that we have, and really begin to cause us to take a step back and look at what are those relationships and what are the things that we need to put towards those understandings in terms of research efforts, resources to address policy issues that may be of concern, or other uses of data that we haven't yet thought about.
What this means is that we have this talented, experienced, trained staff to investigate and monitor environmental health issues, and then to take that information and be able to inform and educate the community.
In collaboration with experts and partners, the tracking program is committed to improving health outcomes across the nation. With better information, the tracking program empowers communities to become healthier. CDC's Environmental Public Health Tracking Program. Better information for better health.
Welcome back. We're talking about the Environmental Public Health Tracking and Biomonitoring Program in Minnesota with Jean Johnson from the Minnesota Department of Health, who is the director of that program. Jean, that video gives us a little perspective of what CDC is trying to do nationally. How many states are engaged in this tracking now?
Well, they just started a new cycle of funding. I believe the number now is up to 26 grantees. So I think it's 25 states and New York City. Okay. Are in the program.
All right. Now, it really talks a lot about data. You have a lot of data. So data are really not much good unless they get used. So how do you make sure that these data get out to the right people at the right time and get updated, and so people can use this information?
Right, exactly. That's a big part of the program. It's not just collecting and analyzing the data for ourselves, but we recognize that other people need to use the data, that other programs and other entities are out there doing great public health work, and we want the data used. So the way we do that with the CDC funding is we develop a portal, a data portal. And so all of this data is brought together and made accessible on the portal, which we call, in our state, it's called Minnesota Public Health Data Access.
Right. And who has access to it?
Everybody has access to it. If you have as long as you have a computer and you can get online, you can find it on our website.
All right. So how are these data being used? What kind of things are being done? What kind of successes are you seeing with this, with data from this tracking and biomonitoring program?
Right. Well, one of our biggest partners in using data is local public health, the county health agencies. We've done a lot of work from the get-go as we developed the data, talking with them about what's useful to them. So they use it in their county assessments. We have quite a lot of county data. Recently, we've been talking to hospitals as they do also their community assessments. We've talked with city planners, for example, who are doing climate adaptation work. We have some climate measures, so we go out and we talk to different groups about what they need and what they can use and make that accessible to them.
And you had talked earlier that you have an advisory board or advisory committee or panel. Right. Who's on that, and what do they bring to that allows this to be a richer and more effective and useful tool?
Yeah. So the advisory panel has been meeting, since the program started in 2007. They are created in the legislation. They have 13 members. Representing various stakeholders to this work. But they are stakeholder scientists, so their mission is really to ensure that we're doing good scientific work, that it's scientifically sound, and at the same time bring sort of their stakeholder interests. So they represent business and industry, the university, researchers, non-governmental organizations, 3 state agencies, and there is a House and Senate appointee as well.
And so what kind of recommendations do they make? Have the things to add to the tracking biomonitoring, or how to display the data, how to use the data? What kind of feedback do they actually provide to you in the program?
Yeah. A lot of it is around choosing topics. What are the priorities, making sure that we are focused on things that are important in our state. But they sometimes also, for example, with our biomonitoring, we share our analyses with them, and they might guide us on a particular analysis or on the interpretation of the data. They really kind of cross the whole gamut of the scientific work that we do, making sure that we're on track.
And what kind of challenges are you finding with this program? I mean, is it a challenge about where you get the data, how you get the data, how accurate the data are, how you meet people's expectations or not? What are some of the challenges that you're facing?
Right. Well, with tracking, as I mentioned, all the data we're getting is secondary, so we need to go out and talk to all the programs that hold the data. So a lot of it is, one thing is sort of the data sharing aspect with tracking. You know, protecting privacy is extremely important. We always make sure that we're following appropriate rules for protecting privacy and data. Those are kind of the big challenges for tracking. Biomonitoring has another set of challenges for the data we collect there. As I mentioned, that's more community-based, so there's a lot of community engagement work that's involved, and the interpretation and understanding of that data and what it means is a
well, let's talk a little bit about that. I've got a slide here on the perfluorochemicals that we'll put up, and it shows in the East Metro area that you've been monitoring, you know, PFAS blood levels. So maybe you could talk through what this slide means so people can understand what this is all about.
Sure, yes. One of the projects that we've been working on for several years now has been monitoring blood levels of the perfluorochemicals in the East Metro residents. We started out with a group of about 200 folks that we've been monitoring who lived in the Oakdale community in particular, where there was drinking water contamination. And we've been just tracking over time how that level has changed. We've measured 3 times now, and we compare that to what you see in the red bar there is actually a national biomonitoring sample. So we have that as a reference point. So what that told us early on, that was that yes, indeed, you know, this community did have higher levels than what we see nationally. But sort of the good news that we've been able to tell folks too is that we do see this coming down. It's coming.
So these are the years. The darker are in 2008, and then blue 2010, the yellow 2014. So they've been steadily decreasing for those different kinds of PFCs, the PFOS, the PFOA. That you're tracking. So it is going in the right direction.
Yes, and this of course is following 2006 when the intervention was put in place, the filtration went in. So we've been able to provide some assurance to this community that levels are doing what they should be doing.
Right. So actually these biomonitoring data actually can be used to evaluate interventions.
Yes.
So like in the East Metro area, for example, what were some of the interventions that allowed these chemicals to decrease in people's bodies?
So for Oakdale, it was the installation of a filtration system in their public water supply. They put in a very large filter system that takes those PFCs out of the drinking water. For folks on private wells, they have filters that are actually whole house filters that are in the home to treat the private wells.
All right. Well, I want to talk a little bit about some of the disparities, because you are really monitoring chemicals that are really of concern to particularly pregnant women and infants, and some populations that are disproportionately impacted by it. So I want to talk about that, but first we're going to take another little break. So we'll be back right after this message.
Radon gas is a silent killer. 2 in 5 Minnesota homes have dangerous levels. Radon is the second leading cause of lung cancer. Is your family safe? Test your home for radon for less than $10. Visit mn.radon.com to order your kit. That's mn.radon.com.
Welcome back. We're talking about the environmental public health tracking and biomonitoring program with Jean Johnson from the Minnesota Department of Health, where this program resides. Jean, in my introduction, I talked about the fact that your program focuses a lot on populations that are disproportionately affected by some of these chemicals, either because they have more exposure than other folks or because they're particularly sensitive to it. So I want to talk a little bit about that and sort of how your program deals with that. And we have one slide in particular that looks at air quality. And I know you put out a report a few years ago called Life and Breath. And so maybe you can explain how this identifies vulnerable populations.
Sure. So yeah, the Life and Breath report, we put this out in 2015, and this was the culmination of about 2 years of work with our partners at the Minnesota Pollution Control Agency to really evaluate what is the impact of air pollutants right here in the Twin Cities metro area. So we used methods that have been developed elsewhere in the literature and by EPA, but we applied them here with the data that we have. So our own health outcome data, we used our asthma data, COPD, heart attack data, combined with our own Pollution Control Agency data on air pollution, and sort of looked at using that methodology, we were able to link those two together to try to get a good sense of what the impacts are. And perhaps more importantly is we wanted to see, are those impacts the same for everyone, or do we see disparities in the impacts? That was really an important question of this work. Right. So what you see in
on the slide, they're darker colors. I assume that means that those are,
right.
places that are more disproportionately affected,
yes.
or more impacted by the air pollution.
Right, that's what we saw, is that the impacts are not shared equally across everyone. When we looked across zip codes, we saw that the impacts of air pollution distribute very much with the disparities that we see in health.
Right. And a lot of these are income and racial, because Minnesota or the Twin Cities are sort of a segregated population. So we have pockets of yes. low income and populations of color in some parts of the communities, right?
Right.
All
yes.
right. And so this was with PCA. So it sounds like you really need to have partnerships in order to be able to both collect the data and also use the data. Is that true? So who are your yes. partners in some of these efforts?
Yeah, so Pollution Control Agency is a very important partner for the work we're doing. We also work with other programs such as our Climate and Health program. I mentioned we're working on developing a number of indicators around climate and health, and that helps the city planners and it helps them in their work, sort of target their work. Cities, local public health, counties, these are all important partners. Indoor air program, we partner with them on developing radon measures. And in helping to promote that information through the data portal. So,
right. And then I have one last slide that really looks at COPD, or chronic obstructive pulmonary disease, sort of the emphysema and the bronchitis kinds
right.
of things. And this really shows that particularly populations of color and American Indians are disproportionately affected. How does your data help to present this and make this real to people?
Right, and this was actually a partnership too with American Lung Association. They're one of our partners in Minnesota, and at the time that we were developing this, we didn't have COPD surveillance in our department. And they basically approached us and said they wanted to look at the data, and we developed a report with them and developed this data on the portal. They use this data to sort of help target their efforts in the state. So they've really been doing a lot of outreach, for example, in the American Indian population here, to address this big disparity that we see in COPD deaths.
Yeah. So this slide and the previous one really points out the fact that the reason for the program is to find out who's disproportionately affected and certainly do interventions. Right. So what are some of the interventions in this case with the Lung Association?
I believe what they've been doing is going out and doing some educational work. And even the tribes themselves, we've shared this data with them as well and work with them, and they're doing their own intervention work. Getting at tobacco cessation is really the big one with COPD. The major cause of that is tobacco. Mm-hmm.
So you've had this program for 10 years. What have you learned, and what direction do you see the program going for the next 10 years?
Well, we've learned a lot. We've learned a lot about, just sort of the methods and the science behind what we're doing. Like I mentioned, the science about how do you link data sets together, what are some of the barriers and challenges in that, who are the important partners that we work with, what are some of the ways we can inform actions and policies. So we've really moved a long way in that direction from just starting from just collecting data to how do we make that data useful. And with the biomonitoring, we've learned a lot about, again, how to sort of the methodology behind it, but also how is that useful? How do we interpret it in a meaningful way for people so that it's helpful? Mm-hmm.
Have you gotten any pushback from populations about biomonitoring? I mean, because this is, as you talked about, data privacy, and it is actually collecting individual data and tracking. Mm-hmm. And you're dealing with some, important issues. Any pushback on that?
Sometimes we have to remind people, sometimes their expectations are greater than what biomonitoring can do. So biomonitoring is just measuring the chemical in the body, but we always say this chemical doesn't come with a return address. It doesn't always tell us where exactly it came from. It compiles the exposure from multiple sources. So with PFCs, for example, there's exposure through drinking water, but there's also exposure through diet and products. And the biomonitoring number doesn't necessarily sort that out for us. So that's been one of the challenges. And the other thing is it doesn't always tell us about the answer to the health question that people really want answered. They want to know, is this chemical causing, my disease, or will it cause disease? And we don't always have the answers.
Yeah. So how do you deal with that? We have lots of data, but you know, when they have a cluster of something, they always want to blame it on environment. And there are many other factors. How do you talk through with people this whole idea of a risk assessment, and which is a complex topic?
It's very difficult, and actually this is one way I think tracking and biomonitoring are helpful. The more data you can bring to the table, you know, the more you can sort of show it sort of right here in River City. This is what it looks like here. I find that that's very helpful for people to see data.
And it seems to be, you know, very resource intensive. Are there enough resources to do all the work that needs to be done?
Right, it is very resource intensive. Our biomonitoring program is really, all of our projects are pretty small because we're working within, you know, the limits of what we have in terms of resources. You know, we wish we had more, we could do bigger projects, but they are pretty small. You know, tracking, we're very fortunate to have the CDC grant and to have all those partners.
Yeah. Well, this is important public health work, and it's certainly opening up a whole lot of new information for folks, and so good luck for the program, thank you for all of the work that you've done with this program.
Thank you.
And I'll be back with a closing comment right after this message.
Test, fix, save a life. My name is Chester Pitts, and I play for the Seattle Seahawks. Join me in the U.S. Environmental Protection Agency in saving lives. Every year, about 20,000 lung cancer deaths are related to radon. What is radon? It is an odorless, tasteless, and colorless gas that can cause lung cancer and may be in your home. Any home can have radon. New homes, old homes, well-sealed homes, drafty homes, homes with and without basements. Testing your home is the only way to know. Testing for radon is an easy and inexpensive way to save a life, many lives. For more information on radon, call 1-800-SOS-RADON or log on to epa.gov/radon.
There's an old management saying that what gets measured gets done. Measurement plays several different functions. First, measurement underscores the importance of the thing being measured. If you don't measure something, most people think that it's because it's either not important or it's not a problem. Secondly, measurement also allows us to evaluate the direction things are going and how different programs or policies might be affecting the things being measured. And third, measurement allows us to better plan for the future. Knowing where we are helps us to plan where we want to go. Minnesota's Public Health Environmental Tracking and Biomonitoring program does all of these things. But it also does one more thing. It allows us to target our efforts to where programs and policies can make the most difference. It helps us to set priorities. In particular, it focuses on those population groups who are most vulnerable to the effects of chemicals found in Minnesota and who are least able to modify their environment to avoid exposure. These groups include newborns and children, women of childbearing age, and communities that have experienced disproportionate exposure to environmental risks. These groups are either more sensitive to the effects of chemicals or are exposed to higher level of chemicals. If we're going to be a healthy state now and in the future, these are the groups who need special attention. Fortunately, the Environmental Public Health Tracking and Biomonitoring program is doing just that. By measuring exposures to these vulnerable populations, we can better address their risks and their needs. Let's hope that it's true that what gets measured gets done. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.